Well, Dr. Fennell, thank you so much for taking time talking to us. I know you have a very busy clinic, and with the COVID, what's going on, and so on. I know there are lots of things to do. So, first of all, how is everything going on with the COVID in Riverview?
So far, we've been very lucky. We still have yet to see our first patient be admitted with this disease. Northern Minnesota, for the most part, the disease is not existing. There's only about 10 or 15 positive cases. There's been no admissions to hospital, nobody who's been sick, and nobody who's been admitted to ICU or put on a ventilator. Nobody's died. So
one of the safest place there.
Very safe place.
Yeah, yeah. And you know, and as well, I think it's as well safe at a different level, because in a smaller hospital, I think there are less people going in and out. And I think there's less exposure, isn't it?
Yeah, I mean, we know this is all about populations, and the more dense the population, the more the high risk becomes. And we're talking about northern Minnesota, where there's mostly an agricultural region. So the towns are small, the populations are much more sparse. And fortunately for a condition like this, we've been practicing social distancing all winter. So everybody's been hiding inside their houses. So we've been a very safe place to be.
Excellent. Well, now, Dr. Fennell, you know, first I wanted to ask you a little about your background, about where you come from, what is your position in Riverview, and a little about your background. Could you tell us a little about your background?
Sure. I'm an expatriate Canadian. I'm an orthopedic surgeon. I've been in practice and trained since 1990, so we're now approaching 30 years of being in the business. My specialty background has been as an upper extremity specialist. So I do shoulder and hand surgery, and I've been maintaining that practice now in northern Minnesota for the last 20 years. And so I've been working everywhere from a level 1 trauma center where I was the head of the upper extremity group for a decade. I then transposed myself across the border, and I've been now working in the rural part of northern Minnesota for the last 20 years, but still maintaining an active practice as a subspecialty practice. And as time has gone on, I've been working here in Crookston the last 20 years. I've evolved to becoming the chief of orthopedics. I'm also the chief of surgery, and I got the title now of chief medical officer for our hospital. So I've been given a lot of different hats with a number of different responsibilities to do that.
Well, I know that you have been a super specialized surgeon for certain areas. Educate a little about this. What is your specialty even in orthopedic? And why would a super specialist choose a small hospital like Crookston to practice?
Well, some would argue it's because I don't make friends well. But mostly what I've done is I've managed to take the background I had working in a level 1 university trauma center and bring that expertise to the rural environment. And it's interesting, the whole concept of rural healthcare and how hospitals have functioned right across all of North America for the most part has been the rural healthcare centers, where their job was to act as triage centers and then send patients into the major university centers. But as we all know, a lot of the technologies got much more accessible and much more miniaturized. So there's really the barriers of doing high-end, highly technical things has shifted over the last 20 years, so that we can now, in small centers, do the same things that they can do in the big centers. So we've created a model here in Crookston, and it's been fun building this over the last decade or so. We're bringing the subspecialists into our little hospital, and then using them as a draw for people coming from a larger region to come to the small rural center. And the small rural center can be every bit as technologically advanced as any major university center. And then it presents a few advantages, because being a small center, you don't have the layers of bureaucracy to deal with. You have a much more comfortable environment for patients to come into. It's easier to manipulate the system so that you have control over things like the staffing, control over things like how things are cleaned even. So our infection rate in this little hospital is unbelievably low. It's down in the 0.2% range for surgical cases. So when you've got a smaller environment like that, you can maintain super tight controls over all the things, and that produces a huge advantage. So as time has gone on, I've realized that I'm in this unbelievably advantageous position of being able to do all of the same subspecialized activities, but in a much more controlled world than you can in a larger environment where there's more people involved.
Now, and I noticed, at least in the last 10 and 20 years, and you actually nailed it with saying that for the technology becoming so available, you're able to provide same care, and some may argue as well even a better care in a smaller, more controllable environment, like a smaller hospital. And I have even heard from some specialists that say hospitals are like people, like surgeons, like doctors. Those who try to be good at everything, they are mediocre as everything. So, and I noticed that these super specialized places is becoming more a destination kind of place to go to get a very specialized kind of medical care. Can you compare, the Riverview to the surrounding place in the musculoskeletal in the environment you are?
Well, the environment we're in, so now we're in northern Minnesota, which is mostly rural. There are some urban centers, and the urban centers, even they're small. If you take Fargo-Moorhead with a population of about 200,000 is the closest large center, and that's basically the size of a large suburb of a major city. So there's no place that's dramatically large, but even so within those parameters, with the population and the medical population, there are limitations of what kind of services are provided. So we've, in Riverview, found an interesting little niche for ourselves in that we're putting in subspecialized surgeons who find that they can provide services that even the much, much larger medical centers, the places that are 10, 20, 30 times our size, aren't providing. And so we're able to find that comfortable little zone that we're working in where we can do those kind of high-end procedures. And as time is going on, we're finding more and more about surgery. It's becoming less time in the hospital. So it's less about the hospital and the size of the hospital and more about the technology and the people that are in the hospital. So I now can do total shoulder replacements in our facility where the procedures are taking us maybe 45 minutes. The average length of stay in the country for a total shoulder patient is about 2.2 days. Our patients are going home in an average about 20 hours. So it's quite phenomenal that we can outperform even the best university centers in the world in a small community like this. And again, it goes back to the control. We've got such tight controls over how we perform these activities that we can get into that top percentile for productivity and function.
Yeah, and and I think that sort of reflects as well the rest of the country, that in many places the super specialized are able to provide actually the higher quality care with lower complication rate, and the data does support that. Now, you're a chief of surgery and you're the chief of staff, chief medical officer as well, correct?
That's correct, yes.
What is the job of a person that has these positions? What is it, what you do in this capacity?
Well, the chief medical officer, let's start with that. Basically, I'm the liaison between the medical staff and the administration. And the administration has their goals and aspirations, and that those are usually fed to them by the board of directors of the hospital. And my job in that regard is to make sure that the doctors are functioning as they should be as a group, and then to make sure that the aspirations of the administration of long-term goals of the community are being expressed. And also to take back from the doctors to the administration any concerns we have as far as how do we perform our activities. So I say I'm kind of that go-between person who's got a foot in both sides as an administrator and as a practitioner. When it comes to chief of surgery, a little bit more limited function there, but much more specific. I'm herd over a bunch of cats to make sure that they are doing their jobs the way they're supposed to. Everything from making sure they're maintaining their licenses appropriately, doing their retraining appropriately, and then when it comes to innovation, making sure that when we're doing things that we're not being cowboys, that we're doing things that are appropriate, well thought out, and appropriate, and that we're doing the best that we can for our patients. So in part, that then becomes who do we keep in the building? Who do we allow in the building?
Yeah.
So having that kind of discrimination that we're going to, and knowing that I personally set my goals for myself of being the best of the best, that I'm knowing that I'm trying to set my own standards of being at the top level of function within the orthopedic community. I expect no less of any of my other surgeons. So what's nice about this is such a collegial environment, and that we're a small organization, so I can see who's doing what. It allows me to maintain that high level of quality, and when if anything awry from that, things show up very rapidly, and we're able to deal with it.
Yeah. Now, I'm assuming, as in your role as well, you're overlooking, like as a chief of the surgery, like complication rate, patient outcome, evidence-based medicine, and as well how to bring and what new procedure to bring to to that surgery room. Is that correct?
Exactly. So we look at all of those parameters, and particularly when it comes to newer procedures, we have to be certain that we're protecting the public. So my role, both as the chief medical officer and as the chief of surgery, is that surgeons bringing in new procedures that hopefully they're innovative, but hopefully they're well vetted and are being performed at the top level that they can be done.
Now, how long have you had exposure to spine? Because spine is not your subspecialty. That is.
No, that's very true. But interestingly, you always look back at people who are your mentors, and the gentleman who actually was the one who convinced the program that I was ended up training in. That was his specialty, was spine, and so I had a long relationship with him, and a very intense relationship with him as doing training, and spent several years actually doing spine surgery. So though it's not something that I aspired to do as a subspecialist, I certainly had a major background in training in it, and I had a lot of exposure to a variety of different spine techniques. And you may appreciate this. I was the very first person to put a pedicle screw in Western Canada.
Oh, wow. So it's not foreign, spine is not foreign to you. Then I would like to ask actually a follow-up question on that. When you were starting doing pedicle screw, what year was that?
That was 1988.
Oh, that is a lifetime almost. But tell me about what was your take on the spine then, in that, in the 80s and 90s?
It was interesting because the back procedures back then, as you're well aware, were quite crude compared to what we were doing now. There was a lot of big exposures and a lot of sewing up to be done at the end of the cases, because you had people filleted open from their buttock all the way up to their mid-shoulder blade region. It was still at a stage where we were still learning about instrumentation that might work. We were changing from dealing with all the kids with scoliosis to trying to deal with adults with degenerative disease. To be honest, the orthopedic surgeons still felt pretty smug compared to the neurosurgeons back then, because the neurosurgeons didn't have a clue about stabilization of spines back in the day. They've learned as the years have gone by from the orthopods, but back then we were the ones still doing the major spine reconstruction things. That's evolved as the years have gone by. So I had a great respect for these people willing to open up backs and then look at spinal cords and decompress the things that were deep down in dark holes back at the day. But it was an area that I felt maybe it was above my pay grade, and I decided I was going to let other people continue with it.
You remember, I'm sure you remember some of those surgeries, and I just reviewed some of the data regarding that. an average spine surgery was a whole day procedure or whole day operation. And before we had pedicle screws, in average, it took patients 4 to 6 months before they could literally ambulate independently. By the time they could ambulate, they have no muscle to ambulate with and walk with, because the pedicle screw, what we use now, stabilize the spine, as you mentioned. And before the age of stabilization, every time patient would stand up, we would take a piece of a hip bone, put it in the disc base, and just brace the patient and just hope the best. And there would be always macro motion, and more ambulation was extremely painful. So what was your experience then? That how long would it take? How long would the patient be in the hospital? What is your memory on how that at that time the spine surgery was?
Well, there's been definitely there was an evolution taking place in so much of surgery, because even at that time when we admitted a patient for a total hip replacement, they were in the hospital for about 6 weeks.
Wow.
And the spine patients were in, for an equally long length of time, and they'd be in laying on their back, and then they'd have their braces made, and they'd be walking around slowly and on narcotic medications for 2 or 3 weeks in the hospital. So it's just, I'm aging myself, showing how far back how we were treating people, from 4 decades ago. But that's how it began, or at least at the time that I was at that stage. We were just starting to do anterior posterior approaches at that point. That was really quite a production, because that involved getting general surgeons involved, and taking down diaphragms, and then putting in chest tubes and having patients in ICU. So it was quite a production to do anything that involved the lower end of the lumbar spine, needing the general surgeons in place, and certainly was a huge production to do anything that involved the upper end of the lumbar spine into the early thorax region, because then we're with all these tubes and chest tubes and ICU admissions. So these were surgeries that made patients very sick for a while. As a resident, of course, after you're violating like that, their guts weren't working, they weren't breathing right, so we had all kinds of problems with lung issues and all kinds of problems with gut issues, and just getting people back to the point where they could breathe and eat and drink again was a major production after these kind of spine operations.
No, but you have had this now exposure in the Riverview for what, 12 years or 10 years to spine surgery, correct?
It's even longer than that, Hamid. I think we're up to about 15 years now with
so,
yeah.
So you have seen not only in your training and so on early on, but as well in your current position, you have seen for 15 years open surgery, and now you're actually in charge of overlooking our procedures, this minimal invasive procedures in Riverview. So you have an inherited knowledge of how it used to be generally, but how as well specifically was in Riverview, even in your professional time. Is that correct?
Absolutely. And so there's a few things I talk to my patients about how they've been transformative and how I treat them. Some of the technology for shoulder replacements have changed completely, so that it's made the procedures much simpler. Other things like for hand contractures, where we're now doing injections instead of surgery, treatments where we're treating like tennis elbow with a platelet injection. These things have changed completely how I manage certain diseases within my practice. So it's been fascinating to watch the evolution of spine surgery, going from open procedures to these minimally invasive procedures, watching how the response of the patients to this has become where what typically had been even a decade ago a week-long admission to now where patients are heading home the next day. And again, with these becoming minimally invasive, all of those other attended associated things that we used to inflict on people with their bowel and all that, these don't take place anymore. So we've got patients going home in 24 hours, sometimes even less, with procedures that once upon a time were staying for 4 or 5 days. And what I still find absolutely remarkable is this is taking place in Little Oak, Crookston. And you can go down to the University of Minnesota, you can go to the Mayo Clinic, and they're still doing it the old-fashioned way. Yeah. They call it old-fashioned, but they still think it's the standard of care. And I'm just going that they think it's a standard of care because they don't understand what the new standard truly should be, which is watching how spine surgery has evolved like we have with other joints, where we're now putting cameras in and doing procedures through scopes and doing minimally invasive surgery. Now spine surgery is truly jumping into that same group where they're doing unbelievably major spine surgeries through minimally invasive surgery. Patients are so much better in their recovery, where now it's like 1 day or 2 days in their home for something that used to be many, many weeks of recovery.
Well, the sad part here is that still 80% of the surgery on the spine are performed old-fashioned open way. And only, so Crookston is among like 15 to maximum 20% of the places that minimal invasively is a daily occurrence. And now the other day, actually we were talking to Dr. Fasharo and Dr. Camden, who are internal medicine, the physician in the hospital. And if there is a complication, these are people who are taking care of those complications. And they were telling us that since we moved from open surgery to minimal invasive, that we have reduced 75% of the complication, like ileus and other complications and so on. Among those patients are getting this surgery. And one of your, literally, definition of your work is to look over complication rate of the procedures and make sure those new, especially new procedures, are advantageous to our patient. And I'm sure, in that process, as you, in your position, you as well talk to other physicians, other doctors, other health professionals. And you mentioned that, you're amazed at how they can go home within a day or two with less complication. But what is the feedback you're getting from the rest of the team in Crookston about how was it before we moved on to minimal invasive, and how is it that we are doing most of our cases minimal invasive in Crookston? What is the feedback you get from the rest of the team?
Well, the feedback universally is almost one of wonderment that we've been able to make this kind of transition. We made a similar transition in orthopedics back in the early 90s, basically, when we went from open procedures in mainly joints to arthroscopic procedures. It took a change of the generation to see the older surgeons depart, the younger surgeons be trained and move into doing these kind of procedures. And it's been kind of amazing to watch you being at the forefront of this spine transition. So we've, like I say, watched this firsthand in our own building. The teams, they almost take it now for routine. And it has become routine, where we can say we're going to do a 4-level spine fusion procedure in our operating room, and the patient's going to be in there at 8 o'clock, and they're going to be done by 10:30 in the morning. That's unheard of in most major centers. We're going to do a single-level spine fusion and be done in 45 minutes. These kind of timelines and the freeing up of resources, because if a procedure only takes that used to take a full day, now is only in 2 hours. It just allows you to do that much more. And so you don't need to be some huge center to be incredibly productive with this. So the approach of the team and the people, the experience we've had has just been, it's been a blessing that sometimes we wonder if we deserve, but it's been amazing to watch.
And certainly that is, opening up resources for more patients in the community and so on. But some of my colleagues are telling me, when I tell them about the procedure and so on, they say, okay, you're doing the surgery under 1 hour. I do it in 7 hours. What's the big deal? What do you think? What is the right answer to that? If somebody says that, well, if I achieve the same result in 1 hour or 7 hours, what is the big deal there? What do you think?
Well, as a surgeon, the answer is pretty obvious. You take a human body and lay them in one position. You leave them there for 1 hour, there's certain changes that take place. You leave them there for 7 hours, and it's a whole different world as far as the metabolic effect on an individual. There's the difference in the pain level afterwards, the difference in the pain medications that you need to use afterwards. I don't recall the last time we've had a patient that's had to have a blood transfusion because of the we're no longer seeing patients who are staying, the extra 2 or 3 days just because their gut's not working properly and they can't eat or drink. We're not putting nasal gastric tubes down patients anymore because their stomachs and the nausea problems that they have when the bowel stops working. So as a surgeon, I look at this and it's a no contest argument. If it's a 7-hour operation, is not the same as a 1-hour operation in anybody's hands. So the patients do much better on every other measurable parameter with this.
As a matter of fact, they're based on the large data. I'm talking about large data on 77,000 cases when they have done this analysis on a meta-analysis across any kind of surgical specialty. It seems that just the time under anesthesia is important by itself. Every 30-minute additional time in the surgery adds 17% to the combined risk of the surgery. And these are humongous data that are leading to this kind of statements. So truly, just the time under the surgery matters. Now, something that I tell my the college, my patient and so on, it's not that we just doing the surgery faster. It's just different kind of surgery with the MIS, with the OLF, that it's just the flow of the surgery is faster. And what that means is that we are not rushing the surgery. It's just you have been in one of those surgeries, Dr. Fennell, yourself? Have you watched?
Yes. Yeah.
Now, do you feel that that you're just trying to be fast, or you're rushing the surgery, or is it?
The fact that it's that much quicker isn't a reflection of that there's some frenetic pace taking place just to try to beat the clock. It's just that the procedure is that much slicker and it can be done that much more quickly. And obviously take that, add to the experience level of the people performing the procedures has a major impact on it as well. But it's being fundamentally a different procedure. You're not opening up things that then you have to spend an hour closing. So inherently the procedure is quicker just because of the steps are different, and the steps can be done much more efficiently and quickly.
One of the things that we have no data on, that it seems that it is not truly a superior skill of Hamid Abbasi, that these surgeries can be done so much more efficient, so much more faster, with less complication, and patient go home so much sooner. 1,000 cases, not a single take back for infection to surgery. 1,000 cases, not blood transfusion and so on. It seems that other surgeons who have joined us are able, actually faster than I have, reach the same kind of experience level. And I know that Dr. Kim as well is doing this surgery a little shorter than I have. And so I know that you sort of keep track of the performance in the war as general. How has it been the transition when Dr. Kim started doing this kind of procedure? What has been your experience?
Well, Dr. Kim's had a tremendous experience as a spine surgeon, was very well trained. His initial foray into it, let's say 6 years ago, I think it was still at a stage where the technology was evolving, and I think he found it initially a little bit frustrating. So he backed away from it. But then as he persisted with it and then went through, probably the most critical step was a very supervised training program, so that he became familiar with very familiar with the new equipment and with the more precise steps. Was taught how to do it in a logical, straightforward fashion. Then the light went on for him, that, okay, this is better, this is different, and I'm going to continue on in this direction. And so as he persisted then over the last, I think 4 years, you've seen a very major turnaround in his whole philosophy of something he'd been living with for almost 30 years himself, where he said, okay, this is how I used to do it, but this is much better. Now I'm going to do it this way. And now he's getting those same kind of results as you've experienced.
As a matter of fact, he has been hitting my landmark with half number of the cases that I had, because I created the soft transition, but I didn't go through it. I did it the hard way, but as training, he has been able to reach those milestones much faster. Now, I have a philosophical question for you. You have seen a lot in your professional life. And in a way, you have seen how things are moving. And most of the time, I notice that changes in spine come gradually, like in increments of somewhere between 3 and 7%, or between 5 and 10%. And there are moments in the medicine that there is a huge push, and there are some game changer technologies and so on. Do you mind, tell us, what you saw first in your field, and do you believe that we are sitting in that moment for the spine?
Yeah, I've been around long enough that I've seen those game changer technologies come. You got to be very careful in medicine, surgery, musculoskeletal surgery, particularly. There's a great desire for people to create technology, and then particularly when it came to things like joint implants, and the world is filled with the litter of the failed systems. But the ones that succeed have risen to the top because they've been built on appropriate science and appropriate technology. So I've seen the transitions where game-changing technology has come along and it changed completely how we do procedures. An example of that would be going from putting on casts for a broken leg to putting intramedullary rods in for managing those kind of fractures, and that becoming the standard of care. And that's something that's only about 25, 30 years old. So this is, again, one of those kind of events where what I'm seeing from the outcomes of the patients, the ability to be able to manage a variety of different pathologies. It's not just a one-trick pony, this minimally invasive surgery. It can deal with quite a variety of different pathologies within the spine. And so because of that versatility, it's, I think, going to dominate how lower back surgery, and for a good portion of upper back, mid-back surgery is done. And it's going to be to a major benefit to the patients. They're going to have less invasion. They're going to have higher success rates. And I grew up in this whole concept, and probably one of the things that pushed me away from being a back surgeon was the amount of failures. It was horrible going to the people's practices and seeing all these failed backs. The patients had had surgery from well-meaning surgeons and then not having the success that the patients were looking for. So if we can eliminate a large chunk of the patient's complications that occur in the acute stages and improve their long-term outcomes, we're going to turn spine surgery into one of those ones where people are much less fearful of it, because they're going to know that very predictably the outcomes are going to be better. So I see this technology pushing us in that direction rapidly. As change comes hard to people, and I think you're going to, as I say, you're going to have to get a generation behind you. The generation ahead of you is probably, it's going to be hard to change their minds, but the next generations that are being trained, and the ones that are 10 or 15 years younger than you, are the ones that are going to be the ones taking the mantle of this and moving it to a new level, even beyond what you're doing at the moment. But this is going to be the direction we're going to go.
Yeah, according to academic studies today, published studies, only in 40% of the cases that spine surgery works in what they're publishing from big centers and so on. Now, we're in a small community. Everybody says hello to you. You know almost everybody in that place. From your experience and from what you hear, can you imagine not knowing about that if 6 of our 10 patients wouldn't improve with what we do? Would you hear about that if from 10 surgeries that we do, 6 of them were failures and we wouldn't really help the patient, as is reported in many academic centers right now in the United States? Could you survive with that, with our service in your place, if 6 of our 10 patients would not improve?
No, that's the one thing about the rural community, is that everybody knows everybody. They go to church together. They're on the PTA at school together. Results in a small community bleed through the community very quickly, whether they're good or bad. And if you're having bad outcomes, the people find out in a hurry, and you will not be performing those services in a small community. So the fact that we've been able to generate this regionally and expand it regionally speaks volumes all just by itself, that the people having these procedures are having great outcomes and are sending their friends and family back to come in when they're having problems.
No, and you know, you said a little about that, but you know, you're friends with lots of people in that community. What is the reputation of or musculoskeletal as a whole overall, and then spine surgery in the community? What do people think about it?
It's they're almost at the point where they're becoming complacent to it because they've now expected such a superior standard of service. They do get to compare it to other places. Our regional so-called competition does not have anywhere near the positive reputation that we have here. And our reputation has expanded in a very large catchment region now, where it's hundreds of miles away from where our hospital is. People know about us. And that only happens when people are telling, you know, it can happen for one of two reasons. One is if you have horrible outcomes, people will hear about it a long way away. But in our case, that's not the problem. We have the blessing that people are hearing about us because they're hearing about the good things that are happening here.
Now, I like to thank you so much. I like to conclude that with one personal story, but I like as well for you, if you have a personal story, I like to hear that as well. My personal story, unfortunately, is not the one personal story. It's a accumulation of personal stories that people go to places, they say this surgery is not possible because you're old, it's too much. You're going to die of the surgery. This is a 2-day surgery. It's going to take you 5 days to recover. They come to us and we do a surgery in 1.5 hours that was supposed to be a 2-day surgery somewhere else. They go within 48 hours home, and the pain that they had for 7 or 10 years is gone. And I hear that too often for that to be a one single story. Unfortunately, this is a common occurrence. But I'd like to hear from you. You hear from the patient as well. Do you have a personal story to share with us?
Well, I certainly have been living through that same kind of transition as you have with the work that I do, where I have now mastered skills enough for patients with arthritis in the shoulder, where when I first moved to Crookston 20 years ago, the oldest patient I operated on was probably about 77 or 78 years of age. And as we've moved with the technology and the skill sets to do these kind of operations, we're now taking patients who are towards the end of their life. Admittedly, they may be in their late 80s, but they're usually very healthy, as they are commonly in this region. And they've got maybe another 10 or 15 years left in their lifespan, but they're having horrible problems now. And these were people that we used to dismiss. We just didn't have the courage, I guess, and we didn't have the technology and the wherewithal to be able to handle these kind of people at that stage of their life. And unfortunately, they were then relegated to a very unhappy, maybe last decade of their world. Now, I know I've taken patients that are quite late in their lifespan, offered them a procedure that's safe, straightforward, and they come back within weeks, much improved. I had one lady, and if you want a real short story, where we put a new type of total shoulder into her. She came back 6 weeks after the surgery and asked me why, if she could stop going to her therapy. And my first question was, well, why did she want to stop therapy? And her answer to me was very bluntly, because I can do everything I want and I don't hurt anymore. And that was really quite astounding, to have that kind of recovery in somebody who is well into their 80s, that they were able to make that kind of amazing transition in just a 6-week interval, to go from having a decade plus of horrible pain and to be that fully recovered in a month and a half. And that's the same thing I'm seeing with your spine patients. We have a gentleman that I got to know who's a coach for the university basketball team. And he was at the point where he was into a wheelchair, was immobilized, and was really seeing, even though he was a younger man, seeing his whole career falling down in front of him, because he was no longer able to walk around in a basketball court and teach university athletes. And he came in, was treated by yourself, and basically you transformed his whole life in a span of about 45 minutes. So we've seen some absolutely remarkable outcomes from these kind of newer procedures.
But as well, I think what you mentioned about the elderly, I think it's a extremely important fact that in the United States, we're getting older as a society. We live longer, and the society is getting older. There are lots of musculoskeletal problem. Now, in that age group, these kind of heavy surgeries are extremely risky, like open surgery or spine surgery. But if we don't fix that, these people are going to be extremely um, in need of help from entire surrounding. And my father used to say, it's hard to be old, but it's even harder to be old and in pain. So practically, not only for those patients, but for the entire surrounding, it's all about just keeping them, pain as much as possible, pain-free, which is most of the time not possible. But as well, the entire family just have turns around their pain. They manage their lives around their pain.
Right. So if we can improve the quality of life of these people for the last years that they live, it makes it so much simpler for their caregivers and the family that are around them. It's very much a virtuous thing to be looking at these people and trying to find out ways that we can help them. And now that we have tools that we can do it, it's remarkable how beneficial it is. If we go back a decade, we couldn't do it. And again, these older people were relegated to to so many other techniques. They were medicated. Then the medications then caused all the problems, and then you were left with the caregivers, often the family members, being constrained by their own lives by having to look after these older people that we're now fixing, so that these older people are maintaining a much higher level of independence.
Yeah, and I think what I'm amazed is that I come from a country that every care, any kind of care, was only available in a big city. And I'm amazed that here in the United States, that is my new home, that in a place like Riverview, in a smaller place, just by bringing the right people and right technology, which is available everywhere in the United States, you can put something that you can do a surgery on it in their late 80s even, and achieve those results. And at the level, if anything, at par or in front of the bigger centers, much larger centers. I think that is why I'm truly amazed, as a matter of fact, of proud of, that we can provide this technique and technology to people in their backyard in a environment like Crookston, and they don't have to drive 8 hours to the cities for their specialized care. That makes me happy, personally makes me happy.
When I worked in a level 1 trauma center, and the university, the term they use is these ivory towers, where you start getting isolated in this center. We thought nothing of asking patients to go, travel 300 miles, 400 miles to come to us, because we were the ivory tower, and this is where you came. Certainly, that's been the humbling thing I've learned as I've been in a rural setting, is the implications and the stress that produces on a family, particularly when an elderly member of the family has to be transported to a new city, to a distance far away, where the family members can't be around easily to help them. So being able to provide those services locally is an unbelievable blessing for these people. So I take great pride in the fact that we can provide those kind of high-level services right here in town, so that people aren't having to travel those kind of major distances. Truly to come to anything that even approaches what you've been doing here at this hospital. Patients are looking at a 5-6 hour drive for 200 or 300 miles in one direction. So I've been humbled by that, learning that being closer to home is much better for these patients. They do better when they're around their families and close to home.
So from everything I'm going to ask you a personal question, not regarding who does it, but if you, after everything if you need a spine surgery, would you ever get open old-fashioned spine surgery?
There would have to be pretty extenuating circumstances for anything like that to take place. No, based on what I've seen, the identical operations, as far as the structure and stability, can be performed in a mini invasive technique. I'm not having them in my back opened up.
Okay. Well, thank you so much, Dr. Fennell. We took too much of your time. Thank you so much for this interview.